This is Let's Read Indigenous Health Governance in UNDRIP. This is a report by Bonita Betty. It was published in 2014, and it was created for the Center for International Governance and Innovation. The preferred model for Indigenous health governance in Canada is community-based. This approach builds capacity and efficiency and maximizes accessibility and responsiveness. It is validated by recent changes in international Indigenous law. The United Nations Declaration on the Rights of Indigenous People, also known as UNDRIP, has emerged as an influential global political and policy instrument in support of Indigenous health governance in Canada. UNDRIP makes nation-state governments more accountable for their actions toward honoring Indigenous rights and treaties. The Declaration establishes an international standard for supporting the human rights of Indigenous peoples, as well as their right to self-determination in all areas, including health. Under the agreement, which it signed in 2010, Canada is obligated to uphold both individual and collective health rights of Indigenous peoples, empowering them to build and maintain their own health institutions and systems toward improving their well-being. UN, which is United Nations instruments such as UNDRIP, may help further health governance rights for Indigenous communities in Canada, even if the agreement does not have enforcing powers. While UNDRIP's support of Indigenous autonomy is evident, it is not clear how it translates into implementation and appropriate changes to official government policies and actions. The Canadian government's poor track record in implementing treaties with First Nations has made some skeptical toward the practical utility of UNDRIP. It could potentially set unrealistic expectations, including the idea that the United Nations can somehow, quote-unquote, gift Indigenous peoples with rights, when in fact Aboriginal rights are collective and inherently flow from customary rights. In other words, the Declaration is not a magic instrument that can somehow correct all the wrongs against Indigenous people. Although the implementation of UNDRIP cannot be guaranteed, it does create a, quote, moral high ground, end quote, and a, quote, starting point for a relationship, end quote, and a, quote, framework for action, end quote. It's a tool, not a panacea. The Declaration can help by facilitating international network collaboration and information sharing to influence governments, policymakers, and health providers. 3 methods of facilitation are profiled here. UNDRIP can inform broader public policy and engage Indigenous peoples by helping to give a public profile to priority health areas from an international political level. Generate ideas and innovation through knowledge collaboration and comparative dialogue on Indigenous health governance. And facilitate forums to help advocate for strategic measures and resources to support community-based health systems. UNDRIP can facilitate Indigenous aspirations, but can never take the place of Canada's constitutional and pre-Confederation treaty obligations toward Indigenous peoples. Indigenous engagement at international policy forums and special conventions can be informative and educational for federal, provincial, and Indigenous policymakers. The United Nations Permanent Forum on Indigenous Issues that meets annually is an example. The United Nations Permanent Forum on Indigenous Issues advises the United Nations Social and Economic Council on many social and economic Indigenous issues, including health. The Federation of Saskatchewan Indian Nations and certainly the Assembly of First Nations and other Indigenous groups have been active at the United Nations Permanent Forum on Indigenous Issues meetings for some time. Though their participation clearly supports the United Nations Permanent Forum on Indigenous Issues intent, even though they may have some reservations on the timely implementation. Clearly, effective profiling of health priorities at the various decision-making levels requires good working communication and knowledge transference capacities among key players in the health networks. They must be able to work together and have sufficient authority to make the decisions stick. The lack of intergovernmental coordination and absence of harmonizing policies across federal and provincial governments have made First Nations particularly vulnerable with respect to poor health and communicable diseases, including pandemics. Good working linkages are required between governments and their health systems at all levels so they can activate quickly when needed, particularly against high-risk health threats. A good example of this link in action was the global response to the H1N1 flu pandemic in 2009. The World Health Organization and the UN member countries rapidly responded to the global health threat through strategic planning, public education announcements, and national vaccination campaigns. Similarly, the organized and collaborative efforts across health jurisdictions in Canada reach the individual level through community-based health agency efforts. Information blitzes and planning meetings occurred across Canada in large cities and small northern Indigenous communities. While rapid responses of this nature are generally triggered by potential global health threats and not daily health challenges, they illustrate that there is sufficient infrastructure across governments and health systems that, if called upon, can be effective and timely. Political will, engagement, and organized efforts are crucial elements for working toward workable collective action. It's also important to note that access to information through global communications, such as the internet, is also becoming better utilized, even by those living in remote northern communities, making them better informed about health trends and other issues. Generating support and innovation in Indigenous health governance and delivery is an emerging area of research interests. Solutions to address multi-jurisdictional challenges and complex health needs are being actively pursued. It is crucial to develop timely research on Indigenous health developments and innovative local practices, both from a practical and scholarly basis. There's ample evidence to suggest that the more innovative models come from the community level, where health programs and services meet human needs in a more direct, responsive fashion. The more direct the investment of resources into frontline healthcare, the better the accessibility and responsiveness of the health system to the people who need it. Often missing at local levels, however, are capacity, resources, and the time required to explore innovative ideas from outside the region and the country. The potential exchange relationship between local and global health knowledge can be very valuable because, if managed properly, it can better inform health policy and program developments at all levels. A frequent policy error is assuming that the, quote, latest and greatest, end quote, health governance model is going to fit everywhere. This is especially trying when it has not stood the test of time and experience. There is no one, quote, perfect model, end quote. Single-tier self-governing health authorities involving provincial governments, such as the BC First Nations Authority model, province-wide entry, are not favored by First Nations in most prairie provinces because of perceived threats of their treaty relationship with the federal government. And while centralized regimes can create positive economies of scale, forcing a fit, quote unquote, can also cause logistical policy and administrative problems that could result in service gaps, inhibit community innovation and capacity building, and marginalize the smaller and more isolated communities. Without local capacity building, programs and services cannot mature effectively, resulting in crisis management and inefficient administration. The practice of advocating at provincial, national, and international levels for improved community-based health systems is not new to Indigenous peoples in Canada. The treaties are an example. Federal responsibility over First Nations health is broadly identified in the Medicine Chest Clause of Treaty 6 from 1876, even though the federal government rarely acknowledges Aboriginal and treaty rights in health funding agreements, preferring to address them as policy positions. While the scope of federal responsibility has been a matter of ongoing debate between federal and provincial governments, First Nations interpret the provision to mean comprehensive medical services, the full basket, or, in Cree, Mewut. Further, First Nations hold that the Section 35 Aboriginal and treaty rights in the Canadian Constitution include health rights. At the time of treaty negotiations, the elders and leaders were worried about the future of their descendants following European colonization, which devastated Aboriginal communities and traditional ways of life. Epidemics, such as tuberculosis, poverty, and poor health were a problem then and remain a concern today. Issues of inequitable funding, lack of access, inadequate health care, problems with national health insurance coverage, insufficient Aboriginal engagement and planning, varying capacity issues across communities, and inadequate frontline and community public health education are some of the health issues that plague Indigenous communities in Canada. Self-determination in health is viewed as the way forward in improving the health of Indigenous peoples. Enabling policy instruments, however, such as the federal First Nations and Inuit health transfer agreements, are limited in that they largely provide for self-administration of certain health programs and services rather than self-government arrangements. Nonetheless, these have provided valuable experiential governance experiences for First Nations health authorities at the community level. While First Nations health agencies struggled with funding inequities compared to their provincial counterparts, there has been ample evidence since the inception of health transfer arrangements in 1989 that Indigenous community-based health systems are a superior way of improving healthcare in Indigenous communities. Next section, Indigenous political activism and international collaboration. The League of Indians of Canada, formed in 1919, provides an early example of national Indigenous political organizing in Canada around issues that remain relevant today, such as treaty and land rights, hunting, fishing, trapping rights, and education and language rights, as well as the need to better the generally poor economic and health conditions on Indian reserves. Other political organizations, including the current Assembly of First Nations, benefit from many local innovators, including veterans of both world wars and other Indigenous community activists who tenaciously lobbied governments to not only address their outstanding treaty obligations with First Nations, but also the basic human rights of all Indigenous peoples in Canada. Veterans returning home became influential advocates for their people after seeing the continuing poverty and after they themselves were denied benefits given to other soldiers. Most Indigenous activism has been culturally rooted in addressing the needs of one's family, community, and future generations. Well-being is broadly perceived as being more than physical health or the absence of disease. It involves a more comprehensive view of life with the idea that all is interconnected. Wellness has to do with balancing the physical, emotional, mental, and spiritual elements of life. From the start, treaties were concerned with providing a lasting legacy of land and resources for the use and benefit of future generations. In retrospect, this was both prophetic and practical economic foresight. The development of natural resources, which sustained Canadian development for many years, also sadly marginalized Indigenous communities to the point of poverty, a situation Indigenous peoples continually strive to change. Things are slowly improving. Through the leadership and organizing efforts of the early Indigenous activists and community leaders, Indigenous peoples are not the passive citizens often depicted in political analyses that measure participation through the lens of federal and provincial voting trends. In northern communities, Indigenous peoples are highly politically engaged in local elections, but appear more strategic in provincial and federal politics. They have good civic participation in community events and still engage in traditional livelihood pursuits. Nonetheless, past legislative and economic injustices through government policies and regulations, such as residential schools, have taken a negative toll on their communities. It is likely that it will take a few more generations for Indigenous health and well-being to noticeably improve. The demographic profile of the majority of Indigenous peoples in Canada has often been likened to conditions facing third world countries. The struggle to improve local health conditions is truly an uphill battle for Indigenous governments and health agencies. In 2013, the UN Special Rapporteur on the Rights of Indigenous Peoples, James Anaya, visited Canada to assess the quality of life of Aboriginal Canadians. His visit made dramatic headlines, highlighting the crisis of conditions in Canada. In a Maclean's article, Anaya is quoted as saying, quote, "The well-being gap between Aboriginal and non-Aboriginal people in Canada has not narrowed over the last several hundred years. Treaty and Aboriginal claims remain persistently unresolved, and overall there appear to be high levels of distrust among Aboriginal peoples toward government at both the federal and provincial levels," end quote. Anaya highlighted the need for meaningful participation by Indigenous peoples on all matters pertaining to their rights and interests. This message is not new and has been a consistent theme in Indigenous politics in Canada. It helps to have influential people such as the UN Special Rapporteur and political organizations such as the Assembly of First Nations profile Indigenous issues at the national and international levels. Unfortunately, quote, "meaningful participation," quote, is also an anomalous phrase that can be interpreted in ways that fall far short of the expectations and understandings of Indigenous peoples. Nonetheless, the policy influence of the United Nations Declaration provides important guiding principles and frameworks that make Indigenous issues harder to ignore. At the provincial level, political organizations such as the Federation of Saskatchewan Indian Nations formally endorsed UNDRIP in 2008, focusing on those elements relating to the implementation of inherent treaty rights. As Indigenous peoples, in particular First Nations in Canada, continue to administer more of their own health services under various funding arrangements, emerging models of healthcare delivery and administrations are being developed. Most First Nations set up health departments within their local governments. Some choose partial program integration in regional First Nations entities. Inability to influence government policies made without their consultation or knowledge by government officials has always been problematic for Indigenous peoples. Engagement at the health policy level, especially at the national and provincial government level, remains largely advisory if it exists at all, with little opportunity for Indigenous peoples to engage in decision-making. As in most instances where governments are concerned, health policy making is political, usually stemming from a political problem needing resolution and consultation. Unfortunately, few processes are in place to allow for meaningful joint conclusion and resolution with Indigenous peoples. Conclusion. In conclusion, the greatest potential impact of UNDRIP at the community level has to do with providing access to the world stage through annual forums and other means. The right to health is both a fundamental human and Indigenous right. UNDRIP suggests Indigenous health governance is key for facilitating improved health status among Indigenous peoples in Canada, in particular for First Nations and rural and northern reserves areas where issues relating to access to health services are most evident. The organizations and networking that formed during the 2009 H1N1 flu pandemic planning offer good ideas for focused engagement in targeted areas such as Indigenous health. Working dialogues at the national and provincial levels are necessary. The Assembly of First Nations has been advocating for the Canadian government to engage in national dialogues with Indigenous peoples toward implementing UNDRIP, and further studies toward the development of an international mechanism by which to implement UNDRIP have also been recommended. It is increasingly clear that meaningful participation or engagement by Indigenous peoples is crucial in working toward the implementation of the Declaration. The end.